Good morning, everybody. I use this medical image algorithm every day. I'm a cytopathologist. Cytopathologists are doctors who evaluate cells under the microscope every day in order to say if they are cancerous or not. So a cytopathologist is a doctor who's going to tell a patient if he has cancer or not. When I'm not watching cells smiling at me, you will usually find me training people in first aid. So one day I said, gee, I'm really good at first aid training. Shall I change specialty? No, because I love cytopathology and I have 2 kids to raise. But is there anything I can do to combine these 2 loves? And here's what I came up with. On the left side of the screen, you can see the first aid algorithm applicable in all clinical emergencies for immediate assessment and treatment of clinically ill and injured patients. On the right side of the slide, you can see what started first as a cytopathology ABCDE, which as a paper was rejected 4 times and then finally published. It's all about publication strategy, right, Sophia? And of course, you can combine these 2. First aid and cytopathology, they don't combine, but they do share the same philosophy. You don't proceed to the next step if you're not clear with the above one. But why am I here in front of you all? Not so much, not so many. Anyway, to tell you this algorithm and not in front of cytopathologists to disseminate the knowledge of the procedure, because it turned out to be a generic algorithm, one that can be used also in pathology and in radiology. And a quick remark for my Greek fellows. When I say pathology, I mean I don't mean pathologia, I mean pathologiική ανατομική. So with this presentation, I'm going to tell you 3 main points. Who can use this algorithm? Who's this algorithm made for? And after analyzing you the acronym, what do ABCD stand for, I'm going to give you a reason why it should be taught in classroom. So this ABCD algorithm is suitable for everybody. Students can use it, professors can use it, residents can use it, and pathologists, oncologists, radiologists can use it as well. It's a useful, practical, and educational tool that will make our life easier because it leads us to a faster diagnosis and fewer mistakes. And here it is. Everything starts with a preliminary stage that is correct. And what is correct? I have a request form and a slide to evaluate under the microscope and say to the patient if it's cancer or not. First thing I should do is to check the number on the slide and the number on the request form. Do they coincide? Okay, so it's for the same patient. I don't want to make a diagnosis for a wrong patient. I cannot stress the importance of this step, but you can all realize how fundamental it is. Then when I'm correct, I proceed to available information. Available information is all the medical record of the patient and his demographic data. That is gender, age, and stuff like that. If I don't have all these, I should first gather this information before I proceed to the next step, which is B. B is body. So I see to my request form that they are sending me a breast. I put the slide under the microscope. Do I see breast or do I see thyroid? Maybe this is a mistake if I say thyroid and they tell me that it's breast. So I need to know which is the topography of the lesion. And next question I should answer at this step, which is very fundamental, is if the sample is adequate. If it's not, there are some adequacy criteria. If it's not adequate, then my chances for making a false negative diagnosis are very high. When I am done with B, I proceed to C. Now it's time to say, to consider morphology and say, is it a neoplasm or a non-neoplastic lesion? If I cannot make my decision with morphology, I use I take out of my toolbox some tools like immunostains or molecular assays or further workup for radiologists. And then I go to D, which is diagnosis or differential diagnosis, where I assess what I see, along with all the available information I have gathered. And when I'm finally done with that, I go to E and write a report for clinicians to develop an optimal plan for therapeutic treatment. Here is an flowchart of the algorithm that depicts all stages and all possible outcomes. I'm not going to go through all of it because I'm now going to give you, I'm not going to show you my dear Prezi, that is I'm going to, in order to give you a better understanding of the algorithm, I'm going to go through a non-user of ABCD and a user of ABCD experience story. They both end up with the correct diagnosis. But the first one, who doesn't use ABCD, experiences feelings of frustration, anxiety, and he has a lot of time loss. The other one that uses ABCD, he is very confident and always in the right track. So this is Lucas. Lucas is a resident of radiology, and he works in a hospital where all medical records are kept in this way, no digital format. We're in Greece. And it's an envelope, hardcore material. This is the ABCD flowchart algorithm, but he has no clue about it. And he receives a mammogram. You can see here, this is a mammogram film, along with the request form. What he does, no. Sorry. Okay, here we go back. What he does, he places straight to the mammogram in front of the light box. You know, these boxes that you see, it's X-rays. And he notices that here there is a nodule, quite irregular borders and spiculated margins. He doesn't like it. It's in the upper quadrant of the breast. And so he goes back to see the request form. The only information on the request form is the age. Not enough, because in order to evaluate this lesion, he needs to know all clinical and medical history of the patient, if it's an existing nodule or not. Suddenly, he realizes that the name on the request form and the name on the mammograph pill do not coincide. So he goes back to the technologist and asks them gently that, to fix the error. They give him the correct request form. And so he proceeds. He now needs the medical history. It's 3 o'clock, and the archives facilities are closed. He phones to the surgery, to the treating surgeon, but he is in the surgery room, and he cannot talk right now for clarifications. So he waits until the next day. The next day, he sees again in the light box the mammogram. He skips the step B about adequacy and defines it as a rather suspicious mass. He now knows, as long as concerns the clinical history, that this is a new finding, so it's not so good, it's suspicious. He consults his specialist, who first indicates that this is an inadequate image. We don't see the pectoral muscle exposed, fully exposed, until the posterior line of the nipple. So what they do, they ask for the patient to have a new mammogram, and everything is okay the second time, and they classify it as a bias for mass. So they need to use, the patient need to have a ultrasound-guided biopsy in order to know what this nodule is. So what he did is he skipped all the first steps and went straight to C. He didn't do correct, he didn't do A, B, he went straight to C. And this led him to many mistakes and loss of time. So now this is Iro. Iro is a student, a 6-year medical student with an interest in pathology. She attends at her free time, she goes to a pathology laboratory for unofficial training and help because they have no residents there. She's at the same hospital with Lucas, and she's a real fan of ABCDE. So she receives a fine needle aspiration biopsy of a breast, and first thing she does is correct. She sees that the two numbers coincide, the number on the request form and the number on the slide, they are the same. So she doesn't want to make a diagnosis for a wrong person, so correct is a safeguard. So she proceeds to step A of the algorithm, which is available information. The oncologist clinic resident, who is also a kin of ABCD, provided with all the main points of the medical history of the patient, because he knows that all available information is a prerequisite for an accurate diagnosis. So she now sees on the request form that is a woman, 42 years old, with a medical history of embryonic rhabdomyosarcoma of the left upper hand 20 years ago. And now she presents with a nodule at her right breast with irregular margins, which is classified as Byrad's 4 category. So with this information, Iro has established the basis of her diagnosis. She goes on to B. She puts the slide on the microscope, and then she sees that it should be breast, because she sees some foam cells here and there scattered around. And about adequacy, the hypercellularity of this smear, it's enough for an adequate image. So now she follows to C cancer. These are horrific cells. You can tell them. These dots are all cells. They are horrific, terrible, with nuclear pleomorphism, lots of mitosis, and they really are terrible and very frightened. So it's crystal clear that it's neoplasm. She doesn't have any doubt about that. And she goes to her consultant, pathologist, to talk about the case. They both agree that they need some stains to perform in order to distinguish and to better establish the tumor type. So they have a differential diagnosis in their mind now, which is either a primary carcinoma of the breast, ductal or lobular, or a secondary one, or a metastasis one, sorry, a sarcoma of her medical history. With the aid of the stains, they decide that it's a new primary, unfortunately, and it's a lobular carcinoma. They give more stains for predictive and prognostic reasons, and they exhibit their findings in a report, all identifications, macroscopic, microscopic findings, and a final conclusion. And with this case, they optimize the communications with clinicians. So I told you until now who can use it. We analyzed the ABCD acronym, and now I will tell you why it should be taught in classroom and why use it. Because such an algorithm doesn't exist. The only available ABCD criteria in pathology is a heuristic for melanoma detection. There is also an ABCD scheme for prostate cancer, but the use of it has been replaced by the TNM staging system. Our ABCD, it's not limited to a specific specimen. It's for every part of it's not for the chest X-rays, it's not for the breast, or not for the skin. It's for every single part of our body. It's a generic one because it can be used for both slides and radiology images, that is for pathology and radiology. It's a new systematic and structured way to orientate medical diagnosis and reporting. It's a well-structured and systematic way of thinking that provides us with a consistent set of steps and rules for a reliable diagnosis. According to the students, it should add an element of fun and guidance to the learning process, and if all medical students are acquainted with this algorithm, in their follow-up professional years, they should be more inclined to provide all available information to pathologists and radiologists, and they will appreciate their role. It can set a basis for a common language among doctors of different specialties. And with this common language, these doctors can communicate their observations in a more coded way, like what's RA, or what do you think about C? and what do you think about D? It can be used by medical instructors to facilitate teaching and enrich lectures, to present a case and to write a case report. And as William Osler, the father of modern medicine, said, a good doctor is one who treats the disease. A great doctor is one who treats the patient who has the disease. This algorithm in an era of personalized medicine, reminds us that we should focus on the patient as a whole and not as just facts and figures. So we saw that everybody can use this algorithm, students and professionals. It starts with the correct states. It goes with available information, B is for body, C is for carcinogens, D is for diagnosis, and E is for exhibit. And we should taught it to our students because by using this ABCD step-by-step procedure, someone cannot deviate from the right course of action. And most important of all is that it leads us to a faster diagnosis with fewer mistakes. So last slide. You can download this from the Diagnostic Pathology Journal. It's an open access journal. And disseminate the knowledge to our students. Let us, with the use of it, strengthen the bridge between patient and faster correct diagnosis, and let it be the first aid tool for those who come across an image and they don't know how to begin interpreting. I wish you have a nice day.
Okay, we have to do some social engineering since we're running out of time. Is Marco here for the last presentation? No. So we have 5 minutes for queries, and then we can continue to the coffee break. Any questions for Christina?
Okay, thank you.
Don't go. We'll be fast ahead if we do it this way.
Okay.
I have something to ask you. You've said something that impressed me, that we should cope with the patient as a whole entity.
Yeah.
We've heard from the first presenter for ontologies. The second presentation was technology-oriented. Mm-hmm. Your presentation is trying to converge things. Mm-hmm. Okay, where does that leave us? That is, how do we use technology? Is it helping us? Is it something we should use with caution?
Of course, technology is there to help us. Everything has to do with how we use it. And for this, we should train and educate our students to use it wisely, and to give them the basis for a patient-oriented medicine, and not just I have a slide and I give an answer. It's not that. It's not that simple. We should be more lovable to our patients.
Let's make the question more specific and move on for the coffee break. The first paper was about ontologies and the social network in a city of Italy, for instance. The second paper was for a mobile application which could be used around the globe. And your presentation is very patient-oriented, mm-hmm. which means presumably that can be used only by a registered physician. Am I correct?
Yes. Yes.
So what are the limits? Can everybody use equipment to proceed with diagnosis on himself and on his surroundings?
No, because you need, some steps. If a layperson takes his, let's say, X-ray of the chest, he can use the algorithm, but he will stop in C because he doesn't know how to continue after C. And if he has some general knowledge, and if he sees something, if he can compare his past chest X-ray with the new one and see that here is nothing, but in the new one I have a nodule, then he can proceed to C. But he has not the knowledge to make the D. I mean, he stops there.
So the last word for a query point to all of you who made presentations. Do you okay. We cannot hear you.
Now? Okay. Since I ended up with the microphone, may I ask the last question? It's more a comment about what you said being useful to physicians. The original ABCD algorithm for emergencies was developed with heuristic methods in order to be useful to paramedical staff also, not just specialized doctors. And I think the ABCD algorithm for pathology that Ms. Zioga developed has Zioga developed has also this possibility, for since I see that ABC, AB at least, can be evaluated by helping staff, right? So the doctor actually doing that diagnosis can take up the procedure after the first two steps. This could be facilitated by some online method. Interconnection between labs with the secretary and then the diagnostic doctor. So it is possible, I think. Like to say something?
Certainly. Yeah, technologies of medical laboratories should be trained in this algorithm as well. It's very fundamental for them, it will be. And also some secretary staff of in a hospital arrangement, but I don't know how further from that it can be used. Maybe one day. I'll try to make an application.
Thank you very much for your attendance. We can go upstairs for the rest of the session.